Mr. Chairman. First of all, I want to congratulate the organizing committee for a wonderful scientific meeting in the last 2 days, which I have thoroughly enjoyed, learned quite a lot. This session would be of interest mainly to transplanters, and this is a very, very important topic for the various reasons which I will elaborate now. I think it's most of us who are involved in transplant know this double equipoise. You all already heard about the word equipoise from Sanjay Goyal, but double equipoise is always balancing the risk to the donor and the need of the recipient. It's a fine balance. It needs to be looked at in each and every case. As we say in surgery, there are never events in every operation, which should never happen. But we accept some incidents, some occurrence. However, in LDLT, as far as the donor is concerned, everything is a never incident. So a donor death is an absolute disaster. Many places, after a donor death, the program closes down till at least they have an external review and look very in-depth at what went wrong. To some extent, even a donor complication or a grievous bodily harm, which every donor suffers because of his incisions and things like that. Psychological harm, and you will see this towards the end of my presentation, this has been overlooked most of the time. And of course, the long-term effects like financial loss and opportunity loss. None of this should actually happen to a donor because he is purely altruistic in his action, and as surgeons and as a transplant team, we have to ensure this. If you look at the ethics of organ transplantation, the ethics that cover living donation is quite different from the ethics that cover deceased donation. While things like equity of distribution, fairness, and justice, that they rule the deceased donor platform. However, when you come to living donation, whether it is directed or non-directed or truly altruistic, I think the ethical considerations are completely different. The ethics that rules LDLT or LD of any organ is autonomy and gift, because it's a gift, and non-maleficence. That means no harm to the donor. Although Asia was in the forefront of living donor liver transplantation, and quite a few transplants, at least in Northern Asia, Northeast Asia, were done in the latter part of the last millennium, the first look into what happens to the donors was this publication in 2003 by Professor Low from Hong Kong. So by then, he could get data on 1,500 donors from various centers in Asia, and the mortality was thankfully zero. There was no mortality in Asia. Morbidity was, however, high, including the need for reoperation in about 1.1% of patients. However, the study was severely weakened by the follow-up of these donors, which was only 15% of donors had a follow-up beyond 3 months. So this study concluded that the long-term outcome of liver donation is unknown, and transplant centers should continue their follow-up of donors. The same paper mentions, at the time of writing, that United States had already recorded 7 donor deaths, and Europe had recorded 4 donor deaths. And you can see the referrals there. As expected, and as most people who do these transplants know, Achilles heel of liver transplantation is the biliary anastomosis. So you can see that in 1,500 patients, the highest incidence was bile leaks and hyperbilirubinemia. The other major complication was wound-related infections and wound-related complications. Subsequently, the Americans had a look at all their data from the A2 ALL data. About 400 donors were studied from 9 centers. The vast majority, well, not the vast majority, but 62% had no complications. At least one complication occurred in 21% of donors, and 2 or more complications occurred in 17%. For the first time, a categorization according to the Clavian-Dindo classification was made, and thankfully, most of the complications fell in grade 1 and 2, but there was a grade 3 incidence and also 3 deaths in this study. Oops. Okay. And there is a mention in this paper about depression. And it noted that 12 patients, or 12 donors, that is about 3%, suffered from depression. This then subsequently, within the next 5 years, the Americans did a further study using the SF-36 survey form, which assesses both physical and mental subscales in complications, and ultimately comes up with what is called the physical composite score and the mental composite score. What they found was, of course, they ultimately looked at 19 studies and about 760 donors with a median follow-up of 10 months. And they concluded all these conclusions. They said that prior to donation, donor quality of life is significantly better than in control adult populations. This may seem strange and maybe needs explanation. However, within the first 3 months after donation, physical domains of quality of life are significantly worse. And this is easily explained because of the operative pain and various other symptoms that the donors may suffer from. However, these authors were very positive, and they concluded that these slightly depressed quality of life parameters come to baseline levels within 6 months in the vast majority of donors. Mental domains of quality of life remain unchanged. So this study did not find there was a major issue with mental problems. The common donor concerns after LDLT included bloating, loss of muscle tone, poor body image, and fatigue. So you can see mostly physical symptoms. So this study concluded that adequately powered, multi-center, long-term studies with donor-specific quality of life questions are required for adequate informed consent for living donors. So in short, they did not find psychological symptoms a major problem. My own physician colleagues in Singapore did this meta-analysis, which is the most recent publication on this, but at least 3 to 4 years ago. And they studied 17 articles ultimately, and about 1,800 donors. And they found an incidence of nearly 11% depression in the donors assessed. This was a combination of self-reported, self-rated, and clinician-rated. So overall, there was a range of 4.47% to 12.8% depression amongst donors. They also found in their study that there were some predisposing factors. Female gender, ladies were more prone to depression after donation. Caucasians, ethnicity-wise, were more prone to depression. And lower education status donors were more prone, maybe lack of information or lack of insight into what exactly is involved. And there was a positive effect of being employed. You were less prone to depression if you were employed. There was significant weakness even in this big meta-analysis. Reporting bias is a possibility, especially the stigma of mental illness, especially in our communities in Asia. the varying follow-up preventing use of regressional model, lack of data on recipient outcomes and its effect on the donor. You know, if the recipient outcome is bad, what happens to the donor? So the authors concluded that although significant efforts in recent years have paved the way for improvements in quality of life, the systematic assessment of depression and implementation of support infrastructure for donors after transplant remains an unmet need. This is the Korean experience of a snapshot between April 2014 and December 2015, where 15 centers were studied, 830 donors. Again, as usually happens in Asia, no mortality. So, very good. Median follow-up, not bad, 19 months, ranging from 10 to 31 months. And this is most of them were right lobe donors. And they had a minor complication rate, grades 1 and 2 of 7.3%, but also a major complications, grade 3 and 4, of nearly 2%. The same team from National University of Singapore looked at 60,000. So this is probably the biggest meta-analysis of donor results and donor complications. And Mark Muthaya, who is a senior author, is a hepatology colleague. And this is what they found. Amongst this large number of donors, the pooled incidence of complication was nearly 25%. And if you see the types of complications, you will see here that psychological was the most common in 7.6%, ranging between 4.9% and 11.5%. So suddenly, psychological complications have overtaken physical complications, it seems, in this meta-analysis. When put in the form of a bar chart, you can see that psychological far outweighed the traditional technical complications we attribute in liver transplantation, which is biliary and vascular. So it may be that we have become pretty good technically, but we haven't really looked at an entire donor issue, which is psychological. I was in Singapore in a reasonably small unit so I was obsessed with small volumes. Can we keep standards in small volume centers? What happens if something goes wrong in small volume centers? So we looked at our data and published a couple of papers. And the reason was this, that volume outcome relationship, although it looks intuitive, is usually fraught with biases. Biases with patient selection, lack of risk adjustment, small sample sizes, and rarity of serious complications, thankfully. So we thought we should focus on the donor outcomes for living donors and looked into the donor selection process, workup donors, reasonably standardized, donor hepatectomy, which is complex, multidisciplinary input into donor preoperatively as well as postoperatively, and extreme low tolerance to donor mortality and to some extent donor morbidity. These are no different from any living donor liver transplant centers. Actually, established scientific techniques like randomized controlled trials, PDSA, are not very relevant when you look at data like this. So all living donors who underwent hepatectomy during a certain period of time, about 204 were studied, and the donors were divided into two case periods. And these are the results. I won't read through them, but basically pretty standard. Most of the donations were actually left lobe and left lateral segment. There were 12 minimally invasive hepatectomies during this time. There was an increase in right lobe donations and a decrease in left lateral segment donations, consistent with decreased pediatric need for transplant. I'll just look at 2 or 3 slides, which are outcome, when you look at outcomes. The first one here shows operating time. And you can see, as we progressed over this period, operating time on the donors decreased. And the second is estimated blood loss. Even that shows a decrease. So these are criteria which you can actually use to look at how you are doing in a continuous fashion. Donors stay in hospital. We started with about a week, and then by the time we ended 200 transplants, donors were staying between 4 and 5 days. And this is the division according to the Dindo classification. Mostly you can see small grade 1, 2 complications, but also 1 or 2 major grade 3 complications. There was no donor death as well. So in conclusion, live liver donation, or actually all live organ donations, are guided by very different ethical considerations compared to those covering deceased organ donation. While regulations sensitive to local culture and customs provide safe platforms for deceased organ donation, living organ donation is much more guided by the ethics of gift and altruism. And negative factors, I call them the 3 C's: coercion, commercial organ trade, and criminal organ retrieval, are always constant threats posing to living donation. Live liver donation is a major undertaking for the donor, posing threats of morbidity and mortality. And all measures need to be put in place to keep these to a minimum with zero tolerance. Both continuous auditing, internal auditing, as well as an external audit, maybe every 3 years to 5 years, need to be done. I myself have been involved in a couple of centers in India where external audit was sought, and thankfully they are still continuing to do, and they're doing well with good results. So data available so far indicates that this can be achieved by strict selection criteria for donors. Surgical excellence, including protocols to deviate from plan and to abort, is a given. It's not an option. Surgical excellence is mandatory, and there is no place for mediocrity or a learning curve. Long-term outcomes for donors, both physical and mental, should be carefully studied and published prospectively, and all organ donors should be offered lifelong follow-up. Thank you very much.